So, and also another concern is the quality of life, because we know that when we are treating these patients, we are giving aggressive treatments such surgery, radiotherapy, and chemotherapy, and we know that we will have neurocognitive impairment, neurologic damage. Also, another concern is the quality of life, because we know that when we are treating these patients, we are giving aggressive treatments such surgery, radiotherapy, chemotherapy, and we know that we will have neurocognitive impairment, neurologic damage. Also, another concern is the quality of life, because we know that when we are treating, we are giving aggressive treatments such surgery, radiotherapy, yes, that we will have neurocognitive impairment.
Pardon.
Please,
I have to mute everyone. Sorry, please.
again, please.
It's okay?
Yes. And I was talking about quality of life. And of course, in the long survivors, we have to talk about second malignancies. But fortunately, these 2 late decades, we have had an explosion of knowledge in the molecular biology, and we began to understand the heterogeneity of the response to the treatment. And also a new concept have emerged, which is the personalized treatment. Next, please. So let's talk about DIPG. Next, we know that it is the most frustrating tumor currently. We have to consider it as a whole brain disease. And of course, the median of survival is very short, with less than 1 year in general. And what we have now in the armamentum is only irradiation that can give a survival benefit of 3 months. In the pre-era of CT and MRI, the biopsies were done routinely, but since the early 90s, it was not done routinely. And while some studies have shown that the morbidity is very, very low, and also the mortality. There have been several attempts for treatment, but unfortunately with failure. And maybe one of these causes is the resistance of this tumor to chemotherapy and target therapy, which may be explained mainly by a relatively intact blood-brain barrier. Next, please. So this is a classical type that we have in our series and that we have treated empirically without biopsy. And you can see that the survival was very short with radiotherapy. Please. Next, please. So came a lot of papers about, no, previous, please. A lot of papers about biology. And we began to understand the biology of these tumors, and we have understand that they are totally different from adult SGG and even from supratentorial pediatric SGG. Next, please. So the studies have shown that we have a mutation of the H3K27M in nearly 80% of this DIPG. This mutation was also found in some tumors in thalamus and also in spinal cord. And that's why the classification of WHO in 2060 has defined a new entity, which is the DMG, and which are categorically a grade 4 tumors. And you can see that we have also other molecular aberrations individually that may represent targets for the future. Next. Next. So no, previous, please. So which is the place of the biopsy now? Yes, it will be probably a standard of care with these two nice papers that have been published recently with very low morbidity and very, very low mortality. And what can we expect in this field is that the work about the disruption of blood-brain barrier will have consequences in the treatment of these tumors, CED and osmotic pump delivery for having agents and maybe radioimmunotherapy and so on. Next. Next, please. So what about medulloblastoma? I know that Nelsie will talk about that, but we know that we have had a consensus in 2012 about the 4 subgroups, which are very totally different regarding demographic prognosis and all these things. And we know now recently that there are maybe other subgroups, maybe 12 subgroups. And that's why the WHO have integrated this molecular information in the classification. And this will allow a better selection for patients and maybe a prediction of the response to the treatment. Next. So these are the implications of advances in biology. And of course, we will never use the classical risk stratification based on the residue and the metastasis. And of course, we will have to integrate routinely the molecular information. Currently in Algeria, we have just integrated the histological criteria in this risk stratification because we don't have molecular biology. And of course, these advances will have a consequence on targeted therapy, but furthermore on the new protocols with even de-escalation or intensification of the treatment. Next. So new risk stratification, yes. And of course, in the current trials with this consensus conference of Heidelberg, and you can see that we have 4 subgroups of stratification from the low risk to the very high risk. And you can see that the survival is totally different from a group to another. And of course, the classical criteria, which are the residue tumor and metastasis, are still here, but it has been added the molecular information. Next. So these are the new therapeutic directions, and of course surgery is still a cornerstone, but the discussion will be in the future about the extension of resection maybe. And of course, the protocol will be all given regarding the biologic ID of the tumor. Next. So what about pediatric low-grade glioma? We know that most of them are pilocytic astrocytoma. Next. And of course, we have had all in our series patients like this. We have the same age, the same histology, but not the same behavior in these tumors. Next, please. Next. So that's why we can understand that with this scheme, when we look at the different mutations, and we can see that the BRAF mutation is more frequent in optic pathway and in the midline, and it is very, very low in the infratentorial pilocytic astrocytoma. That maybe can explain the difference in the behavior. Next. So this BRAF V600E mutation is common in PLGG, and 1/3 of them will occur in the midline. And we know that it will confer a poor outcome when we treat with conventional therapies. These patients will have a progressive disease. And also there is a matter of concern in these patients, which is the extension of resection. And maybe the great hope will come from the inhibitors of BRAF V600E, which are already used in some craniopharyngioma of the adult and in other disease outside the brain. Next, please. So also other target therapies such as the mTOR inhibitors, which have been a lot published in the subset of the subependymal giant cells tumors in the tuberous sclerosis complex. Next, please. What about ependymomas? Next. So currently what we are doing, we do gross total resection, subtotal resection, and we look always to the grade 2 or 3, and we do or do not irradiation and maybe sometimes second look surgery. Next, please. But we know that now that we have several molecular variants of ependymomas, and which is very important to note is that probably in supratentorial ependymomas, the non-RELA and non-YAP1 fusion are not probably ependymomas, they are probably glioblastoma, probably embryonal tumors, and the treatment in these cases is totally different. And now, of course, we know very well the difference between PFA and PFB. Next. Next. So these are the tools for subgroupings ependymomas, and unfortunately in immunohistochemistry we just have H3K27Me3 to make the difference between the PFA and the PFB, but otherwise you have to have either a FISH or a methylation profiling. Next. Next. So this is one of the consensus statement, and maybe in the future we will have a de-escalate therapy in some group of ependymoma, particularly in the PFB. Next. So what is important to say is that the histological grading is not a useful criteria as a risk stratification marker, because we know that it is a subjective criteria, because neuropathologists are not often agree with each other, and sometimes even with themselves. And maybe in the future, we will have a subset of patients that will have only surgery without irradiation and the problems of irradiation. Next, please. Just a word about craniopharyngioma. We know now that most of the childhood craniopharyngioma have a CTNNB1 aberration, which means that the Wnt pathway is involved. And there are several preclinical trials with potential targets, and that I hope will lead to systemic therapies that could lower the need for aggressive treatment. And we know so is aggressive the surgery and irradiation in these patients. Next, please. So yes, it's a great hope, all what I have said, but this is true in a special world, maybe in developed countries, but in the era where we are talking about global neurosurgery, global, which is a notion that are very trendy. What about the low and medium income countries, since we know that the majority of pediatric patients will come from these countries? Next, please. I will talk about Africa because I'm African and I know very well this continent. And people must know that, for example, many countries doesn't have immunohistochemical techniques. And even if they have, sometimes there is a lack of markers. And the techniques of molecular biology are sometimes available in North Africa and South Africa, but not done routinely. Maybe there is an exception, which is the Hospital 57 in Egypt, but it is a very special hospital, and it is not always the case in all these other countries. So the main consequence is that we will not treat our patients according to the new protocols. Next, please. So what are the solutions? Of course, the developed countries have to assist the poor income countries. And for the medium income countries, maybe we have to fight as a pediatric neuro-oncologist to convince the investors and maybe the politicians. And for example, our pediatric neuro-oncology group could add recently these tumors in the national cancer plan, but we are waiting the consequences. And of course, next, please. Next. We can pray, of course, and whatever is our God. Next. Next. So things are going quickly, and I will use this sentence of Winston Churchill, never, never give up. Next, please. And thank you from the Pediatric Neuro-Oncology Group, which, as you see, is a female group. Our radiotherapist is a male, but he was taking the picture. Thank you so much, and I apologize for the technical problems.
Thank you, Pat, for your presentation. It's very good presentation. We have understand the importance of molecular biology in the future in the treatment of the childhood tumors. Frédéric, I give you to speak. Frédéric.
Yes, so should we have time for a couple of questions now, or should we wait till the end?
Professor Boop, I think that we will make the presentations and make the discussion if you permit, please.
Okay, all
Thank
right.
you.
Very good. Our next speaker then will be Nadia El Abadi, talking about lessons learned in the management of childhood ependymoma. And I think most everyone knows Nadia. She's professor of neurosurgery and head of the Department of Neurosurgery in Rabat. She's assistant secretary of the WFNS, president of the Pan-Arab Neurosurgical Society, past president of the Moroccan Society and MANS, Mediterranean Association, past chairman of the WINS WFNS committee, and she's very involved in the Africa 100 project, training neurosurgeons for the rest of the continent. So, Nadia.
Thank you. Are you hear me? I share my screen.
Yes.
It's okay. Okay, the screen. Okay, so thank you, Professor Eric Boop, for welcome, even virtually, for your as our guest to moderate this webinar. And everybody knows Professor is one of the most expert and master in pediatric neurosurgery. Thank you again to be with us today. And first, allowed me to express my thanks to the organizer for their kind invitation, especially for the two chairmen of the WIN committee, my excellent friend Sociétè for this great effort, and also for Nabila Tirlich. She's doing a lot behind Professor Sociétè, and also thank to Nel Cizanon as the chairman of the Pediatric Neurosurgeon Committee, WFNS committee. So within the existing consensus for the best management of pediatric infratentorial ependymoma, surgery is the most important step, the perfect aim before complementary radiotherapy. That, however, remains a challenge even for the most well-trained surgeons because of the vicinity of important brainstem and cranial nerves nuclei. This is particularly difficult in some cases, in some situations, as a lateral extension toward the CP angle. As you know, ependymoma is the third most common brain tumor in children, and its incidence is approximately 10% of all posterior fossa tumor in childhood. And although these tumors seems to be pathologically benign, most of the patients will still lose their lives because of this pathology. And approximately 170 new pediatric cases occur each year in the USA. I found it in one nice paper from Professor Eric Boop. And Africa, including Morocco, there is a paucity of descriptive cancer data, especially on pediatric brain tumor. And this study conducted in Morocco showed that ependymomas accounted for 7.6% of all childhood brain tumor. So clinically, ependymoma comprise a heterogeneous group of neural tumors that affect children and adults. The majority are seen in children under 7 years of age. And I shows a well circumscribed midline tumor, compression, the fourth ventricle, and hydrocephalus is very, very common, as you know very well. Turing peak on the spectral MRI might rather suggest of medulloblastoma than the ependymoma, and the most frequent location at the fourth ventricle, strictly intraventricular, with extension sometimes outside through the Magendie or full spine MRI for leptomeningeal and spine metastasis is often required. It's very important to do it. And we would like to focus on and discuss some aspect of surgical technique for the treatment of ependymomas that we consider effective surgical removal and avoidance of complications. As mentioned, obstructive hydrocephalus is frequently seen, and there is a high probability that it will be resolved after the tumor resection in many cases. But if the CSF diversion is unavoidable, it seems that an external ventricle drainage can be preferred to the placement of the VP shunt. We always put the refrontal ventriculostomy as the preferable access, because after removal of the tumor, the third ventriculostomy can be done through the same burr hole, if, of course, there is a need for among children. The approach to management has remained strictly similar over the past decade. Surgical resection to the without unacceptable neurological sequelae, followed by postoperative involved irradiation. This is one of my cases. Just I will share with you these cases because we will see why. Old who presented with acute raised ICP symptoms and the emergency room. And as you can see here, this is severe hydrocephalus. That's why a shunt was inserted first with improvement in another department outside of Rabat, and then I operated on her tumor that revealed that to be ependymoma grade 2. And we use the telovelar approach. I will not go through this approach. Everybody this approach very well. It seems to be easy to realize without injury to the eloquent areas. And in this image, you see this telovelar approach. You see the image in the beginning here of the operation. You see the tumor, and the end of the operation. We leave here a small residual tumor on the floor of the fourth ventricle. This is a limit for this surgery, as you know very well. And in this video, well, it's work. If the tumor, in these cases, the tumor is large and extended to the depth, the uvulotonsillar and medullotonsillar space on both sides should be dissected here and here, and the tonsil should be retracted superolaterally, and to achieve the good vision and visualization of the area. And this approach can one view of the fourth ventricle as you've seen before, and so that it will be enough to remove laterally, as you see here, the extended tumors. And the lateral recess opening method is applied when the lesion is located, as you see here, in the most lateral portion of the fourth ventricle. And you will see in the end, you can finally, we use the endoscope to explore all the cavity to avoiding a residual tumor. And you see there, here, the insertion here of the tumor of the fourth ventricle. As I said, I mentioned before in the last slide. So this is the post-operative MRI, and 3 months ago, after the operation, showing a small residual here in the roof of the fourth ventricle. Even it says to me per-operatively that I have achieved the gross total resection. She had radiotherapy post-operatively, as Suad said. We can wait and see, or give the radiotherapy in the grade 2 ependymoma. We decide to perform the radiotherapy after surgery. So 1 year after, she had a relapse recurrences, which obliged us to reoperate her again with the 2 centimeter tumor. And this is the film of this operation. You see here the adherence. The dura is white and strong. And then we open here the arachnoidite. You see the arachnoidite is very, very strong. We dissect slowly and gently. Here you see the cerebellum, right cerebellum hemisphere. We continue to dissect, of course, the arachnoid, and you see here the recurrence of the tumor. And we continue to dissect every the vascular, the arteries, and of course, maybe here in the end, you the pica, right, and the left pica. You see here the floor of the fourth ventricle, and you see here when, as the first operation, we have the invasion of the floor of the fourth ventricle. So another type of difficulty of this tumor is the CP angle ependymoma, is an anatomical variant of ependymoma in which young age at diagnosis and anatomical inaccessibility are key negative prognosis factors. Using the surgical techniques described slide, gross total removal can be achieved in 19 sometimes, but reported by some papers, than 95%, and approximately 4% in near total removal with moderate morbidity. So the lateral type tumor showed a significantly lower oops, no, I think this one, no. Okay. Lateral type tumor showed a significantly lower 5 years cumulative survival rate, and main survival rate compared to the other type, I mean mid-floor or type or roof type. It has been described that lateral tumors are the most difficult to remove because of the extension, as I said in the beginning of my presentation. And in order to achieve maximum resection, many neurosurgical technological devices can be helpful, of course, to surgeon to manage a better preoperative strategy. This development microsurgery and the application of neuronavigation, sometimes an endoscopy, as I show you before, provides safer environment for the resection, and intraoperative monitoring, very important tools sometimes used to localize the cranial motor nuclei. So survival of patients who receive a gross total resection range from 66 to 80%, compared with 0 to 7 among patients with subtotal resection. Unfortunately, gross total resection historically was achieved only in all 46% of patients due to tumor location and the risk of unacceptable neurovascular injury. So this clearly shows that gross total removal should be the aim of posterior fossa ependymoma, as it has proved by to increase the progression-free survival in about 70 to 80%. And post-operative radiotherapy improves the recurrence-free survival of patients with intracranial ependymoma, and 5-year survival rate with those when the dose is a little bit superior 45 degree or more, range from 40 to 87% is very important. And relapsed is an extremely poor prognosis with 5-year overall survival reported decreasing. Median time to recurrence or progression is widely distributed at 18 to 45 months, and approximately 9 to 10% of patients develop leptomeningeal dissemination, as it has been reported by several studies. The role of therapy in the management of ependymoma, Suad told us about that, has been extensively studied but remains controversial. Not routinely recommended outside, of course, the context of clinical trials. And the improved biologic understanding nicely exposed by Suad of pediatric ependymoma has generated significant clinical and translational research needs national management strategies and develop novel approaches targeting molecular pathway. We hope all of us that we will succeed in this matter. So despite multimodality therapy, 50% patients with ependymoma experience a relapse, and majority of this is poor after a relapse, as you know very well. And patterns of failure seem to be more local in about 80% and distant in only 20%. Those local control is the survival key. And many reports of prognostic factors have been published in the literature. In most of them, longer survival is associated with complete removal, and the extent of tumor removal is influenced by the anatomical location, as already said, especially in the CPS angle. Also, many reports had concluded that under 5 years old has the strongest prognostic relevance with a high incidence of lateral recess ependymoma, which turn out to be particularly poor in prognosis. Adjuvant radiotherapy has clearly improved local control as well. So in conclusion, the treatment infratentorial ependymoma in children is a challenge for neurosurgeons, neuro-oncologists, neuroradiologists. The standard of care for pediatric ependymoma has long consisted of surgical resection to the greatest extent acceptable, followed by adjuvant local irradiation. And before ending, this is my first case of ependymoma Hajar, operated 20 years ago. That time she was only 7 years old. She is now 27 and mother of young boy, as you see here. And she teach mathematics, how incredible life can be. And, now become the doctor of all the family, of course. I wish the very same to my youngest patient, Rania, operated only 1 year ago. Thank you so much for your attention.
Thank you, Najia, for your excellent presentation. We understand the difficulty of treatment, neurochirurgical treatment of ependymoma. This is very good intervention. Maybe I give the speaker of Frederick. Frederick, it's you to present the next speaker.
Okay, very good. Our next speaker, Nelsie Zanon, will present on medulloblastoma current treatment from genetics to the clinic. I think everyone knows Nelsie. She's pediatric neurosurgeon at Federal University in Sao Paulo, Brazil, chair of the Pediatric Neurosurgery Committee of the World Federation, a member of the WIN WFNS Committee, and chair of the WIN Brazilian Society of Neurosurgery, and president-elect of the Brazilian Society of Women in Medicine.
Good morning.
Yes.
Thank you very much for the introduction. Congratulations, Soad, for this very interesting meeting, and thanks for combining WIN Neurosurgical Committee at the World Federation and Pediatric Neurosurgical Committee. It's a pleasure for me to be here. My screen is sharing okay for you?
Yes.
Yes, okay. We'll talk some words about medulloblastoma and some words about different population treatment and classification. Just some words about the population. We are in the planet 7.7 billion today inhabitants and around 50,000 neurosurgeons. And the fertility rates are in the countries like we see here, Indonesia, Nigeria, India, is in Africa and Asia. And the pediatric population also are in these continents. And the youngest continent we have is Africa, is below 20 years of age. And the other is Asia and Latin America, where I live. The median age 31 years old for the population. And just before entering the subject, to remind us that more than 80% of the childhood cancer occur in the low and middle income countries. And for these patients, more than 19 are not in the healthcare system. They can't be there. And medulloblastoma is the most common malignant brain tumors between 4 to 10 years and represent 20% of the central nervous system malignant tumors. The classical classification are well known by us since a while, classic desmoplastic nodular with extensive nodularity and large cell anaplastic one. Since 2016, the WHO added the molecular biology, and more than the 4 groups we knew came out other 2, SWH and non-WNT with the group 3 and 4. Also, we have the immunohistochemistry helping us to add in research and try to find out the target therapy is the meaning for all this research in the last years. Try to improve our results after surgical resection. There is a paper from our country with more than 1,000 brain tumors analyzed below 21 years of life, and the results were similar or not so substantial difference between the series reported in the literature for the first world. With the Pediatric Neuro-Oncology Society and Neurosurgical Society, we tried a few years ago to establish a protocol to treatment of medulloblastoma. But before starting protocol, we decided to revise the radiological and pathological diagnosis to know if we are really treating the same pathology that we are talking. Our motivation is try to develop the new technology and try to improve the diagnosis before reach everyone a molecular analysis, because it's not available for everyone until now. And the results are not surprising that the pathological revision was discordant in more than 60% of the diagnosis. Is not afraid because it's similar to the literature, but even though they considered clinical relevant, it wasn't linked to the medulloblastoma, because the medulloblastoma was very well diagnostic done even in the revision. The clinical relevant difference was in the gliomas tumor, not in the medulloblastoma. And just to have an idea, most of these patients were analyzed without knowing the 4 subtypes. It was only based in histological analysis. And medulloblastoma, it was 96% concordant diagnosis. It tells us that we are ready to start a protocol to treat these medulloblastoma patients. Just one case that justify our intention to revision this histopathological analysis. This young boy, 2 years old, was diagnosed with medulloblastoma after the first microsurgical resection. In the revision, the results came ependymoma. After recidive or regrowing in this region, the diagnosis was ependymoblastoma, and maybe it was only became worse. It was the third operation became anaplasic ependymoma. And the risk criteria for medulloblastoma are well in practice, in clinical day by day usage. The standard risk is child's older than 3 years, no evidence of metastatic disease, and post-surgical residual tumor less than 1.5 centimeters. The high risk group is younger than 3 years, significant residual disease following surgery, and anaplastic or metastatic disease at diagnosis. The treatment include the standard risk for more than 3 years old is maximum safe surgical resection, like Nadia told us about ependymomas, current chemotherapy with craniospinal radiation and bust tumor bed, usually followed by adjuvant chemotherapy. And in the high risk group below 3 years of age, the high-dose chemotherapy as irradiation to avoiding irradiation strategy, and with non-high-dose chemotherapy during induction, followed by a reduction dose of conformal radiotherapy in the bed tumor. In the several series on the literature with the standard protocol, the overall survival rate is on 5 years, more than 85% of these patients is quite good. Just we need to remember that the long side effects outcome concern for these children are neurocognitive defect, hearing loss, endocrine dysfunction, increased incidence of secondary malignancy, and unpredictable relapse in this heterogeneity survival outcome. The new decade, maybe it tried to bring to the clinical practice or the clinical research, the basic research we are doing now, and try to find the new drugs for this treatment. And between the basic and the clinical, we have the translational research and try to incorporate new biomarkers to validate these new research clinical trials. On this group that we revised this histology, a small sample was analyzed, and the medulloblastoma was around 1/3 of the posterior fossa tumor, and most of them was necessary to treat hydrocephalus. And the majority of them was referred to the other departments, came already with a VP shunt. And this standard management we do is craniotomy, microsurgery in the ventral position. If the hydrocephalus is not treated, we do, or not previous shunt or previous endoscopic third ventriculostomy, we perform AVD at the same time that we are doing the microsurgical approach. And during this approach, 1/3 of our patients need external ventricular drainage at the moment of the surgery. The neuronavigation is exceptional, is only when we have small ventricles and with a huge posterior fossa edema, try to help if we have edema during the surgery. Posterior fossa complication, fortunately, was transitory, and the overall survival, it was around 8% too. And in our country, we have universal healthcare for free. The difference between public and private patients, it's only technology. Because the specialist team are quite the same for both medicine we have here. Just one example, this 6 years ago, it was a classical medulloblastoma, pre and post-operative, and standard treatment. The complication she got was 3 months transitory mutism. It was a low risk standard protocol, and she needed a VP shunt during the radiotherapy period. And rewarded, it was good results. Wow, 7 years after. And just in summary, the last decades have clarified the molecular variants, at least 4. But we have now more than 12 subtypes of medulloblastoma identified in a biological way. And again, to remind us that low and middle income country, the number of deaths in infection disease and parasitic disease is 60 times higher than the deaths from cancer. And in the post-pandemic times, maybe we can do our best, like a physician and a human being, to decrease disparities, to give and share our knowledge more than to ask for, and time to work together. Thanks for your attention.
Thank you, Nelsie, for your very good presentation. We have understand the medulloblastoma, and Frederic, you call the next speaker, present and call the next speaker, please.
Okay. Our next speaker is my next door neighbor, Professor Alam Okal is Associate Professor of Neurosurgery at the University of Arkansas, which is where I began my career. She's a fellow of the AANS, the American Academy of Pediatrics, and the American College of Surgeons. She's on the executive board of the International Society of Pediatric Neurosurgeons and an officer in the Joint Section of Pediatric Neurosurgery. She's been very involved with global health and will give us a lecture on low-grade gliomas of childhood and new concepts. Alam, good morning.
Good morning. Good morning. Bonjour and merhaba to all of you from United States. Thank you so much for your kind words, Dr. Boop. I really appreciate it. You're a great mentor. I'd like to start by complimenting my co-lecturers here. I think I call them the Iron Ladies. So I am very honored and privileged to actually be on the same platform with the Iron Ladies, who are pioneers of female neurosurgeons in the field. I was asked to talk about pediatric low-grade gliomas, and I do not claim to have the huge experiences like my other lecturers have, or you, Dr. Book, but I do have some humble ideas about the pediatric low-grade gliomas. Rather than talking about them in very detail, I just wanted to concentrate on the new concepts And especially I wanted to just, maybe ask a couple of questions about, thought-provoking couple of questions, which I thought that would be useful for the young audience here. I have no disclosures to make. So these are my questions when I look at the pediatric low-grade gliomas. So are there any advances in technology of neuroimaging for diagnosing or pre-surgical planning of these tumors? Have we made any advance? We're talking about gross total resection and its effect on overall or progression-free survival in most of pediatric brain tumors. But are there any advances in surgical techniques to achieve that gross total resection or new surgical concepts? Of course, we have to talk about the molecular and genetic advances and their correlations to outcome and treatment planning in especially low-grade gliomas. Brief introduction starts with general description of this low-grade tumors. And then we know that they constitute the largest group of the brain tumors in children aged 0 to 18 years of age. There's no peak, the peak incidence we know that it's in the first decade, but there's no gender predilection. They're compromised of several distinct entities. They historically have been grouped and graded by lineage, histological appearance, location, and clinical behavior. They're very heterogeneous. But the World Health Organization's brief description is grade 1 and grade 2 tumors based on histological features are the low-grade gliomas. Molecular profiling techniques and such as gene expression, the next generation sequencing is increasing our understanding, as our previous lecture said, of the CNS tumors of the childhood. But the WHO 2016 classification take these molecular and genetic advancements into account. And this is like the classic 2016 classification of pediatric low-grade gliomas. We're mostly, talking about the, astrocytic tumors, which are pilocytic astrocytoma, which is the most common type in pediatric tumors. We're talking about subependymal giant cell astrocytomas or polymorphic astrocytomas. Not going to talk about all of them in detail, but in a general sense. The other glial tumors that are low grade are the DNETs, gangliogliomas, gangliocytomas, and then diffuse astrocytoma. When I look at these tumors, with my humble experience, I look at them in two ways. And one of them is the location. The location to me is, important. And I think to me, it's very important to understand and differential diagnose these tumors. Look at them as infratentorial tumors as well as the supratentorial tumors. This is a paper from Dr. Sievert and her colleagues. And when they look at the pediatric low-grade glioma, cerebellum is the most common location no matter what. The cerebellar hemispheres in about 10 to 15% of the patients. The optic pathway hypothalamic gliomas are mostly seen in some underlying genetic syndromes such as neurofibromatosis. The spinal tumors are not the topic of our talk, but it's less than 5%. I think, in commonly, for looking at their location and the facts related to location, I think that tumor location is still helpful to classify or differentiate these tumors. It correlates significantly with the histological types and effects of symptomatology, but most commonly for me, it actually is a good prognostic factors when look at the resectability of these tumors. So the grade 1 pilocytic astrocytomas is the most common histological type, like we said. It accounts more than 20% of the brain tumors, and it can occur anywhere in the central nervous system. The hemispheric ones tend to be in the older children and adolescents. The chiasmatic hypothalamic tumors tend to be in younger children, and they're mostly related with neurofibromatosis. The diffuse fibrillary astrocytomas is more frequent in the supratentorial region, midline structures, and the cerebral hemispheres. The SEGA is typically related to tumor sclerosis. Well, what this location tells us is, unlike adults, pediatric low-grade gliomas can occur anywhere in the central nervous system, and luckily they rarely transform into big. The one question that I had was, is there any imaging that actually advanced our field so we can do a better preoperative planning or better, like, differential diagnoses for these tumors, or anything that we can actually achieve without even doing, surgery for these or getting a piece or a biopsy for these tumors. However, there are not a lot of imaging advancements because most of these concepts are concepts that we know over the last 10 years. The advanced imagings are the functional MRIs, the perfusions, the DTIs, but they have some technical difficulties, especially when done in children, young children, and their availabilities, like we're talking, are still limited in the developed or developing countries. But this is a new paper from the Lancet Oncology from 2020, and the RAPNO, which is the Response Assessment in Pediatric Neuro-Oncology Working Group, which is an international consortium looking at the imaging guidelines of pediatric brain tumors, especially looking at the response of the treatment. Well, their recommendations did not really include any, those of DTIs, functional MRIs, or spectroscopies as gold standard of diagnosing or treating or looking at the response of treatment for these low-grade gliomas. They actually recommend that like known available, T1, T2, or contrast studies are actually the gold standard for diagnosing diagnosing these tumors preoperatively and looking at the response. So there's not much of a change. One thing that I am excited is something that we also have here is a magnetoencephalography. I think the magnetoencephalography is a new concept, a new machine that has been around actually for 10 years, but is being more commonly used to understand the brain development, especially in children. And it's gaining increasing acceptance for the non-invasive mapping of language as well as motor and sensory areas. And the younger children can tolerate it because it's just a little helmet. They sit comfortably in a machine rather than like going in their tube. So it is much easier to obtain these images in some experienced centers. I think the functional mapping or, looking at the eloquent brain where there's eloquently located tumors is important, not for maybe, what we're going to do or manage, but it also helps with like parental counseling prior to surgery, looking at possible outcomes, giving them more information, as well as also surgical planning. Looking at the treatment and what the advances in the treatment of these low-grade gliomas, I think the surgical extension, I think there's a lot of good papers that are coming out, and we're going to talk about the molecular advances, but the surgical excision remains the mainstay of treatment, with exceptions. Those exceptions are like deeply seated, non-progressing, not symptomatic, maybe, tumors, especially with genetic syndromes such as NF1, like the optic glial pathway tumors or hypothalamic tumors. Patients with complete tumor resection typically do not require any therapies. The gross total resection can be achieved in 70%, more than 70% of these tumors, resulting very good overall survival and progression-free survival up to 99% and 94% respectively. If, however, there's radiographically visible residual tumor, the progression-free survival drops down to 50%. But when you look at the overall survival, it is not as bad. Patients with unresectable and or progressive tumors will need adjuvant therapy or usually need adjuvant therapy. I think one of the main papers, very prominent papers that is published in PLLG is the paper that comes from Dr. Wistov and his colleagues in 2011. They looked at surgery and they looked at gross total resection as well as near total resection and subtotal resection. Most of their tumors in their cohort was in the posterior fossa tumor. Gross total resection was defined as no visible tumor at surgery or in post-op imaging was achieved in about 64% of those patients. And most of their tumors were juvenile pilocytic astrocytomas. For children in whom gross total resection was achieved, the progression-free survival and the overall survival rates were excellent. And the gross total resection was the only highly predictive factor of progression-free survival in low-grade gliomas in their cohort. And this has been actually validated and looked at in multiple other papers following this, and this has not changed. But interestingly, when you look at the near total and subtotal resections, it didn't matter if you lived a little bit of a tumor behind or a big tumor behind, they did have significantly lower progression-free survival. Interestingly, when you look at the overall survival, there was no difference when they look at like histological type, like location or surgical residual. So overall survival in patients with low-grade gliomas, even with some disease left behind or progression, is still good, more than 55 to 60%. So, you know, this paper tells me that we should aim for gross total resection, but we should also be careful about like the eloquent brain, and if there's deep-seated unresectable tumors that we may not need to actually do heroic actions to pursue them. However, there are advancements in surgical techniques such as neuronavigation, intraoperative electrophysiology, imaging, OA craniotomies in children, cortical mapping, and minimally invasive approaches. The two things that actually excites me is the new two techniques in surgery that I want to share with you is the minimally invasive tubular retractor system that some centers use. I don't use it, but it's like using like tube system through like spine cases through the eloquent cortex with navigation and microscope, and try to resect the deep-seated small lesions through this small hole without causing any significant damage to the surrounding important tract. The other paper that came just out in the Journal of Neurosurgery is the laser ablation techniques that they use for some high-grade and low-grade lesions, including epilepsy surgery and epileptogenic lesions. This is a paper that was just published, and laser ablation therapy is still very young. They had only 86 patients, but their results show that this is a promising techniques where you can only go and then do a thermal ablation of deep-seated tumors with good progression-free survival. So what do you do for the residual unresectable tumors if we're really thinking that the gross total resection is the mainstay? The 5-year survival, as we said, in incomplete resection is still more than 85%. So adjuvant therapy is for progressing and or unresectable tumors only. This has not changed. The radiotherapy is not appealing anymore, so therefore it's not used as the first line of therapy. And prospective trials established that it's actually effective in local control. But when you weigh the side effects of the radiotherapy with the progression-free survival, that the side effects actually a lot more in the long term. Proton therapy is promising, and Dr. Indalitico published a paper in 2019 that shows very good results and low side effect profile with the proton beam therapy that can be used for some of these tumors. Chemotherapy is, going sky high. There are a lot of, trials and protocols, but several chemotherapy regimens show good control of the low-grade gliomas, especially in the optic hypothalamic pathway. But classically, a monotherapy is preferred, and vinblastine is most of the time the first-line therapy for many centers. Vincristine and carboplatin is the second line in most of the places. I think the most exciting thing for young neurosurgeons is, for everyone, I guess, is just the molecular and genetic advancements in low-grade gliomas. There has been substantial increase, and this is a summary of all the mutational and molecular alterations in pediatric tumors. I like this diagram from Dr. Pollack that was published in 2019, where it shows the locations as well as the genetic mutations and alterations in low-grade gliomas. But if we highlight the important thing is there are 3 pathways. One of them, and the most important pathway, is the mitogen activated protein kinase pathway. This is a BRAF. And BRAF is a human gene that encodes a protein called BRAF, and it's a proto-oncogene. The genomic alterations of the BRAF are two. One of them is duplication and fusion, and the other is the BRAF V600 missense mutation. When you look at the reports coming from molecular and genetic studies, the reports suggest an association with better outcome with children displaying BRAF fusion. Most pediatric pilocytic astrocytomas are actually contains the BRAF locus, and they have transcription between BRAF and the KIA. And over 90% of the sporadic PA arising in the cerebellum and half of the PA arising in other locations have that gene fusion. So it is there, and it's actually very important for the PLLG differentiation. The lower progression-free survival is mainly related to BRAF V600 mutation, which is one single mutation in valiant glutamate. And it's thought to be more prominent in pleomorphic central astrocytomas, diffuse astrocytomas, midline and deeply seated tumors, and gangliogliomas. The mTOR is a specific pathway that is related to, subependymal giant cell astrocytomas, and the inhibition of mTOR using rapamycin or everolimus is increasingly used in SEGAs instead of the surgery. And the last but not the least is the receptor tyrosine kinases, which is a large group of alterations, genes, and mutations. Here is my, coming to the end, is algorithm for the PLLG treatment. Stocklin and et al. Published this in 2016, and this is what I use. So for clinical diagnosis, I look at the tumors and locations, if it's resectable tumor or an unresectable tumor. If we achieve a resectable tumor with gross total resection, then the observation is the main way to go. If there's a little bit of a tumor and there is no progression or relapse with good and favorable histopathology, observation and frequent follow-up is actually a good way of treatment. Unresectable tumors, I think you have to look at it, it is like, there's room for surgery, or if you do a resection, is there room for partial resection? And if you do a partial resection, then you have to look at the symptoms and symptom progression-free survival. If there is progression, then you go for chemotherapy first and maybe radiation therapy second. For NF1 and tuberous sclerosis with SEGA, the treatment algorithms are different. There are multiple ongoing clinical trials related to the molecular and the genomics of subclassification of the tumors. But one of these papers just came out, and I think it's going to be the mainstay when describing outcomes and prognostic factors as well as genetic alterations. This is a paper that just came out from Toronto. Ryle et al. In Cancer looked at more than 1,000 low-grade gliomas in pediatric patients. They looked at molecular types and alterations and clinical correlates. And they did a risk assessment stratification looking at the genetic alterations. They took the BRAF mutations, the V600E mutations, and F1 mutations a step further and looked at multiple other genetic alterations and rearrangements. So their risk stratification based on alteration of the types effectively, and this is a long paper, so I'm not going to go through this a lot, but the advances in understanding of the molecular and genomics of these tumors is advancing our field further and very quickly. So what are the predictors of outcome? The presentation, survival, and functional outcome of the low-grade gliomas are determined by a complex system of multiple factors. I think the tumor-related factors, as I try to describe, is histological type, location, and resectability, and clinical presentation, such as hydrocephalus at presentation. The treatment related to extent of surgical resection, chemotherapy, volume of dose, radiation, and molecular and genetic therapies are also predictors of outcome. Patient-related factors such as age at diagnosis, underlying genetic syndromes are also predictors of outcome. But we now all know environmental, such as social and family status, education, availability of these new concepts or new models of treatment are also very important predictors of outcome in patients with pediatric low-grade gliomas. Especially, we were talking about low and middle income countries where those new concepts may not be readily available, and that affects the outcome of these low-grade gliomas very much. In conclusion, I think our understanding of pediatric central nervous system tumors has expanded tremendously, like all our lecturers described. The molecular characterization enabled by extensive collaborations between clinical centers, multi-centers, international centers, will build the next generation of clinical trials. And I'm hoping that that will be readily available for everyone around the globe, all the children. And I think we're leaning towards less aggressive, more effective treatment paradigms and also individualized treatments. Thank you so much. This is where I will conclude, and I'll take questions at the end. Thank you.
Thank you, Aylan, for your very, very good presentation. And now, Frederic, please call the next speaker.
Well, our final presentation of the session is one of the most difficult topics in all of pediatric neuro-oncology. And fortunately, Professor Zohra Habibi will be our speaker. She's Associate Professor of Neurosurgery at the Children's Medical Center in Tehran University, a member of the Iranian Pediatric Neurosurgery Committee, and has over 80 publications on her CV. She'll be speaking to us about craniopharyngiomas, history, current, and future care.
Thank you so much, Professor Boop. And it's a pleasure for me to be among you all great neurosurgeons. And among you, I'm speechless, but as you know, craniopharyngoma is a debateful and controversial topics, and I tried to take a look to these challenges and controversies. Craniopharyngoma is one of the most challenging brain tumor because of proximity to optic apparatus and hypothalamus. And although histologically low grade, it can be locally aggressive due to compression and adherence to surrounding structures. But the important point is that due to unpredictable natural course and long-term sequels of various treatments, the ideal management of this tumor has been debated over several generations of neurosurgeons. The first report compatible with craniopharyngoma dates back to 1850s, and the term craniopharyngoma was first coined by Frazier and then became popular by Cushing. As everyone knows, it's an embryonal tumor arising from the remnant of Osteomodium and primitive oropharyngeal mucosa. It's a rather rare entity comprising only 1 to 4% of all intracranial tumors, but it's a very challenging and controversial topic. It has a bimodal age distribution, one between 5 and 14 years and the other between 50 and 74 years. Half of the cases present during childhood and adolescence. There are two histopathological patterns, adamantinomatous and papillary subtypes. Adamantinomatous resemble ameloblastoma in the mandible and occurs in children more than adults. Wet clotting and finger-like interdigitations are diagnostic feature. And papillary subtypes mainly occurs in adults with the feature of monomorphic squamous epithelium. The interesting thing is that the two histopathological subtypes have different molecular markers, so that ACP has mutations in beta-catenin and SHH signaling pathway, while papillary subtypes have mutations in BRAF oncogene, as you said, that Dr. Baptiste said at first presentation, which encoding MAP kinase signaling pathway. and both subtypes present PDL1 or programmed death ligands. The prognostic value of these molecular markers are under investigation. There are different classification systems for craniopharyngioma to choose surgical intervention. The most commonly used classification system is anatomical classification with 4 groups which are defined according to anatomical origin, including intracellular subtype, as you can see, originates from the intracellular part of the stalk, and prechiasmatic subtypes in the second column originates from the anterior part of the stalk and can elevate optic chiasm and anterior communicating artery. And the retrochiasmatic subtypes in the third column originate from the posterior part of the stalk and usually grows in posterior direction, so that the chiasm usually remains in its normal position. And finally, intra-third ventricular subtypes originates from the failure of ventricle. The other classification was described by Paget based on hypothalamic involvement. 3 groups were defined in this classification, including grade 0 with no hypothalamic involvement on imaging, as you can see on the superior panel. Grade 1, in which hypothalamus is displaced or abutted by tumor in second row, and grade 2, in which hypothalamus is involved so that it's no longer identifiable on images, as you can see in the inferior panel. In terms of clinical presentation, a vast spectrum of clinical manifestation may occur because of neurovascular elements being compressed or invaded by tumor. But the important thing is that symptoms of pediatric craniopharyngioma are often delayed and the tumor has enough time to reach to a considerable size. Children usually present with endocrine problem, insidious visual loss, and intracranial hypertension, while adults often present with visual symptoms. Hypothalamic damage is an important issue in craniopharyngioma. Hypothalamus is a collection of multiple nuclei which exert control over body hemostasis. And any insult to these signals and structures may cause different problems, including sleep disorders, abnormality of tears, thermal dysregulation, and hypothalamic obesity, which is very common. It occurs in 60 to 80% of patients because of hyperphagia or inappropriate energy control. And sometimes a patient may attempt suicide because of this kind of obesity. Neurocognitive and behavioral problems are other important issues which can be seen in 10 to 30% of patients. Symptoms including confusion, impaired memory, academic problem, and so on may be induced, are supposed to be induced by a mass effect over the frontotemporal lobes. So neuropsychological assessment should be a component of clinical management in pediatric craniopharyngioma. For diagnosis, MRI is the imaging modality of choice, which can show tumor size, shape, consistency, relation to surrounding structures, and so on. But while MRI is the mainstay of treatment, CT still has a role in detecting calcification in tumor or bony changes in sella and skull base, and hydrocephalus in case of acute deterioration. After diagnosis of craniopharyngioma, therapeutic decision-making is debated. Recent advances in stereotactic radiation, chemotherapy, intracystic therapy, and so on have added to the armamentarium of treatment. But surgical resection still play an important role in many cases. On the other hand, the tumor is considered unresectable by many authors, and high rates of recurrence have been reported. Taken together, in the absence of class 1 evidence, the question of which is the best mode of treatment cannot be answered yet. However, there has been a growing trend toward less invasive treatment during recent decades. But the debate of aggressive versus less invasive treatment is ongoing, and many authors and many pediatric neurosurgeons advocated gross total resection to minimize tumor recurrence, and others recommended more conservative treatment, more conservative approaches to minimize the morbidities. But this ongoing debate has at least the benefit of suggesting a customized treatment plan for each individual patient. Novel risk-adapted strategies focus on the following goals. First, relief of raised intracranial pressure, then reverse of visual symptoms, and restoration of endocrine problems. And finally, prevention of tumor recurrence and progression while minimizing morbidity and mortality. Surgical options for craniopharyngioma, as everybody knows, are different microscopic transcranial approaches, and then endoscopic transsphenoidal approaches, which may be somehow challenging in pediatric population because of small size of sphenoid sinuses. That's why a bilateral approach is recommended, and almost always a vascularized nasoseptal flap is used for reconstruction of defect in skull base. And the other option is less invasive techniques for cystic craniopharyngiomas, which can be managed by repeated aspiration with or without intracystic administration of therapeutic agents via a reservoir. After surgery, after attempting a gross total resection, rate of gross total resection is about 60 to 80%, from whom 50 to 100% may have a deterioration endocrine problems, and up to 50% may have visual deterioration. The other issue is post-surgical management of electrolyte and endocrine disturbance, which is very important because most of patients may develop a kind of water electrolyte imbalance after surgery. Also, ACTH and TSH deficiency should be corrected because they can mask the presentation of electrolyte imbalance and diabetes insipidus. But about radiation therapy, we should say that radiation therapy is a part of contemporary strategies for craniopharyngioma nowadays, but there are still concerns regarding radiation-induced toxicity like vascular and cognitive problems or secondary malignancies. Additional concern is that responses to radiation may be different between cystic and solid components, so that there is potential risk for cyst enlargement during radiation, and sometimes this cyst enlargement may be symptomatic. Systemic chemotherapy is seldom considered for craniopharyngioma. Instead, targeted therapy is on the way. As it was mentioned in the first presentation, BRAF mutation in papillary subtypes have made these subtypes targetable with BRAF/MEK inhibitors, while adamantinomatous subtypes may be a good target for SHH pathway or beta-catenin pathway inhibitors. Both subtypes may be targeted by PD-L1 inhibition. But after all of these treatments and choosing among these multiple approaches, outcome and quality of life is very important in these patients regarding long-term survival, which is as high as 80 to 90%. The craniopharyngioma clinical status scale was developed to assess perioperative function and post-treatment outcome based on 5 axes of neurological, visual, endocrine, hypothalamic, and educational status. And the last point is that the future of craniopharyngioma maybe in the realm of molecular and environmental investigations and also intervention. You know, we don't have targeted therapy in an underdeveloped country like Iran, but I hope in future molecular and microenvironmental therapy should be available all over the world. And in conclusion, craniopharyngioma remains one of the most difficult brain tumor to treat. And in this situation, a multidisciplinary approach and workup should be stressed. Don't forget, the pendulum swings back and forth between aggressive versus less invasive treatment. And in this situation, an individualized plan should be tailored for each individual patient. While maximum safe neurosurgical resection is essential while minimizing unwanted morbidities. Thank you so much for your consideration and thank you for your time.
Thank you, Zara, for your presentation, your excellent presentation. We understand craniopharyngioma. It's very difficult pathology. And we have a lot of problems when we treat this pathology. Frederick, you have something to speak or to all speakers. Frederick.
Yes, I think time for questions. But that was an excellent overview of craniopharyngioma. It's one of the most difficult subjects. Very well done.
Thank you so much. Thank you.
So Nabila, do we have some questions from the floor, or Professor Brook and Morad will begin the discussion?
Right now.
I'm glad to begin. A question for Nelsie and Nadia, since they both spoke on posterior fossa tumors. Can you tell us a little bit about posterior fossa syndrome, and is there a way to avoid it? And when it happens, how do we manage it?
Thank you, Rick. Your question is about the complication on posterior fossa surgery, including mutism.
Yes.
Yes. I think it's maybe more challenging for us to see or try to prevent happen even in very good skills hands. I think try to avoid is learning curve, but not also including what kind of tumor we have. I think a good MRI before try to see if we have invasion on the brainstem. We can try to not go so further and try to keep and to stop before. But I think the neuromonitoring maybe is a help, but is not all the answer. Maybe if we have all this neuromonitoring, we can have this posterior fossa syndrome in postoperative period. About treatment, I think there is not a formal or a rationale to do every patient with a kind of the same therapy. I would like to listen about Najla, and maybe all the panelists can answer about.
Thank you, Nelsie. I think I completely agree with you concerning this syndrome, because we need, when we do surgery, we try our best to, of course, avoid to to be more aggressive against the brainstem, especially on the floor of for the ventricle. I show you the cases that I have in the first time. First operation, there is invasion of the brainstem, but I can't go over the brainstem. I let little bit millimeters residue, and this residue is a relapse in 1 year, and I go over in 1 year after, and the prognosis doesn't change a lot of, because I think if I was more aggressive the first time, maybe the complication, or more complication what was happened. This is why I think when we have is the limit, as I said in my presentation, the limit of surgery is when we have of course invasion of the brainstem, and even we have intraoperative monitoring help, but not a lot in this when there is invasion. I'm not sure at helping a lot when there is an invasion. I think we'll be aggressive to the brainstem. And when it happened, I think it happened. I had two, 3 patients on the beginning of our series. I think in the 19 maybe. And when this complication happened, we didn't have enough to do, because generally in our context, in Moroccan context, it's very difficult to to have the patient in ICU for a long time, because it costs a lot, and there is many complications after that, and the family is not always have the have money to manage this patient. Is very difficult to manage as complication. Thank you. I think if there is more, as Nelsie said, more panelists, they have more experience with this syndrome and how to manage it, because I know in our experience we don't have any most thing to do in these cases.
Yes, Suad, you can.
Just to say about this posterior fossa syndrome, we have made recently a retrospective study about our patients, and we have analyzed several parameters, such as the approach, the type of the tumor, the volume of the tumor, but unfortunately we didn't find any significant factors that will drive to this posterior fossa syndrome. And furthermore, before in the past, we were working just as neurosurgeon with the children, just with a neurological examination. So we were looking just to the main symptoms, such as mutism or lability of emotion. But now we are working with the neuropsychologist in our department, and it seems that the frequency is very high, because sometimes the symptoms are very subtle. And I must say that I don't know really if the fact of the invasion of the brainstem is a main cause. We know that it is probably the dentatorubro-thalamic tract. So I don't have any experience in DTI. I don't know if DTI will avoid that. I don't have this experience, but I know that also in many countries, this problem is still remaining, and Professor De Rocco have published many papers about that and about the frequency of this symptom. What we do in our department is just giving some corticosteroid. I know that it doesn't have a rational validated, but we give them because these children doesn't have any contraindication. And what we are doing also is that they have a follow-up with our neuropsychologist. And we are looking also to the school results performance, because we know that sometimes these are only this subtle symptoms such as decrease of performance in school that will be the symptoms of this syndrome.
Right.
Thank you, Suad. There is another questions. I have questions for all the speakers. What about the limit of the resection in the medulloblastoma? It's total, you prefer total resection or just biopsy?
Medulloblastoma, Dr. Murad?
Medulloblastoma.
I think we have already the answer. If we can do a safe total resection, we sure improve the life of the children. The ideal protocol is try to do a safe resection with a small amount of the tumor, less than 1.5 centimeter square on place. But I think the doubt came if you have invasion of already new, or you have supposition that there is a brainstem invasion. Some papers tell us that we have already 20% brainstem invasion. On this case, I think quality of life and quantity of life is a philosophical, but also a human being decision. We try to don't damage, to don't give, don't resect all the tumor. Doesn't matter what cost the child will pay it. I think it's necessary for us to be in a safe zone. If we have good anesthesiologists, if we are doing a confident surgery, if we are taking out the tumor and the children is good, I think it's better try to do our total resection, but avoiding blessing this child. Or if I answer your question.
Thank you.
I have just a comment about the notion of the safety zone entry is different, because here we are in the tumor, and tumor don't respect the safe zone entry. So this is the reason why in my experience, I prefer to let a minimal residue in some places when there are invasion of brainstem, and respect the quality and quality of life, as judicially Nelsie said, that to be more aggressive and to have a huge complication and post-operative. Thank you.
Agree.
Can I make one comment?
Yes. Yes, Aylan.
So as I gain more experience, I think I came to believe that the political and economical determinants of health is more than anything else, is more important, especially when I go around, probably less than you with my humble experience, that I see that it's actually one of the main predictors of outcome, especially in childhood specific diseases such as childhood brain tumors. The predictors of outcome is not the surgical technique, maybe, because I think that there are excellent neurosurgeons all around the globe, but it's like the techniques and advancements, and then the post-operative care, such as the rehabilitation or neuropsychological or school care after posterior fossa tumors, other low-grade gliomas, or some advances in treatment, such as availability of the molecular and genetic techniques for diagnoses. This is so saddening for me, but I came to believe that rather than surgical technique or resection, that those are the most predictors of outcome when we look at specific diseases in childhood.
Thank you, Aylan. Thank you. Frédéric, you have another questions?
Please.
I think that excuse me, Professor Boop, we have two persons in the audience that have asked to make comment. our professors, Professor Hamlishi, and after him, Professor Bouyoussef.
Thank you very much. Thank you, Suad. Do you hear me?
Yes.
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 Yeah. Thank you very much. I'm very happy to attend this webinar, and I would like to thank all the speakers for their excellent presentation. I must say, lady speakers, because I hope that next time you will accept at least one gentleman to participate in this webinar. But by chance, we have two excellent gentlemen as the coordinator of this webinar. So very good representation. Anyway, I think that I would like to say for both chairmen of the women in neurosurgery, Dr. Suad Bakhti and Dr. Zanon of pediatric neurosurgery, how this webinar is important, and how it shows also, I think, for people who involved many times at the level of the WFNS and for the leadership today of the WFNS, how the position of the women in these committees is really efficient, and how it can give us such educative webinars and gathering. All speakers, of course, the topic pediatric oncology is one topic who is showing us this disparity existing between developed and less developed countries, which we call low and middle income countries. And you have insisted on the lack of technology, for example, regarding the molecular biology techniques, regarding the maybe other technologies like advanced MRI and so on. But I would like to add that the problem in our places, as I see, of course, today, most of the participants in this webinar are from the low and middle income countries. The main problem, of course, when we look to Africa, is the lack of neurosurgeon. So first we should have a neurosurgeon, and then the technology is coming with well-educated neurosurgeon. For example, if you look to these techniques of molecular biology or advanced MRI techniques, they are existing in many places today, but they need also neurosurgeons who are educated in these techniques and who are, of course, encouraging the radiologists and encouraging the pathologists to develop this technology. So I think that it's important in our educational talks and in our discussion with our young colleagues and less young colleagues in different countries to emphasize this issue of having neurosurgeons well educated and, of course, then developing this technology. The last comment and maybe question is regarding the use of adjuvant treatment, mainly the radiotherapy. I heard, for example, in ependymoma, in grade 2 ependymoma, when we have a remnant tumor, which is quite frequent, and also in craniopharyngioma. And in the conclusion of our nice talk of our colleague Zara from Iran, she's shown us how we are divided between being aggressive or respecting the quality of life. And maybe today, I think the one of this adjuvant treatment, which is the radiosurgery, is quite very useful in this remnant tumor, either in ependymoma grade 2 and in craniopharyngioma. better, of course, than radiotherapy, mainly in children. I don't know what is if there is a comment from the speakers, and also from our colleague Rick Boop. And also I would like him to make a comment on the question he has raised, this problem of posterior fossa syndrome, because it's not something easier. I can tell you that in our practice, we just started to succeed in the management of these syndromes in the last 2 decades, since we have a neurointensivist dedicated to neurosurgery. Since that, and with a neurologist also dedicated to neuropsychology and re-education. This is the only way to get some success in the management of these syndromes, and to keep the patients as long as possible in the intensive care. Thank you.
Yes. One of speaker who can
just about the ependymoma, Professor Hamlishi, ependymoma grade 1, grade 2. I mean in infraentorhinal in childhood. Radiosurgery, of course, between radiotherapy, and then he had when he had recurrence, one little bit more than 1.5 centimeters, he had the gamma knife. I just go fastly. This is why I don't speak about gamma knife in these cases. And when I review the literature about radiosurgery and ependymoma too, there is no consensus. The radiotherapy is more consensual, but no radiosurgery in the ependymoma variant 2 in the child. This is just for answer your question. I'm sure that you are. Of course, even a candidate to the gamma knife. However, it's different, as you said, as everybody know about pharyngoma. Pharyngoma is, in my opinion, is one of the tools that we need to use with the surgery, with the medical treatment, and with the sometimes just seeing the patients. Maybe my colleague from Iran have another comment about craniopharyngoma and radiosurgery. Oh.
Another commentaire or questions?
Professor Klamisch, thank you very much. You are talking about the lack of neurosurgeons in several countries, especially in Africa. And we are thank you for your effort in the last decades. You are forming a lot of neurosurgeons that are working already in the field. You are doing your job. Maybe we can build other centers like you did, and like you showed, that if you are training the local neurosurgeons, probably they are able to still doing and to work better with time. Because we see some of colleagues that are forming in another centers, when they are back, they are not necessarily able to put in practice the local neurosurgery because they was training in high-tech neurosurgery field. And when they are back, it is like in our country, you need to do by yourself a lot of stuff, improvising something and do your best to the answer for the patients. And thank you very much for your work on the World Federation. Reward for forever. Thank you.
I agree.
Je demandé la parole.
Professor Bouyousef, oui.
Our moderator, Dr. Book, Rick, you have a comment about the posterior fossa syndrome?
Well,
In
the only
your,
thing
in your
was-
experience?
I'm afraid I have more experience than I wish I had, and I don't have the answer. Except that I think the comment that these children, that Suad made, that these children have long-term cognitive impairments that interfere with schooling and the ability to live independently is probably the big take-home lesson for that. Regarding radiation, I would just comment that I think the job the radiation oncologists do is every bit as technically dependent as the job that the neurosurgeon does. And a good, experienced radiation oncologist can be a great resource to us, and they can help our patients. But poor radiation oncology can do as much damage as poor neurosurgery. There was one other speaker, or one other person in the audience that had a question, I believe. No?
Professor Bouyousef?
Bouyousef, I have seen Bouyousef raising his hand.
Professor Bouyousef. Professor Bouyousef. Maybe we can have another question. I will call him immediately. I think he had a problem of connection.
I'd like to do a question for all the panelists. Did you have molecular biology on your day-by-day life for every single patient, or only in a research protocol is available?
This is a question for our countries or development countries?
For all the panelists, Eileen, Nadia, Soret.
I am hesitating to answer this question because I think I have the luxury of using all the resources that are available to me. We do have a tumor bank, and we do have all these molecular techniques on a day-to-day basis that we send our tumors to be looked at. So yes, we do. And, we use them very, with in line with the established protocols. That's why I can just I'm hesitant to talk about it a little bit because it's a luxury for me.
We'll be there. Don't worry. Question of time.
In Morocco? You want to?
Yeah, you want me to say something about? Yeah.
Yes.
In Morocco, what we have introduced very earlier was the immunohistochemistry, which was introduced late. And now in the routine, there are many markers who are added in general, routinely in main I must say university neuropathological centers. But the molecular biology is still limited. It's not existing in all university centers. But we have, for example, in Rabat, I think there are 2 or 3 labs who are doing this. But in general, not really routinely. When it's asked by clinician in either neurologists, neurosurgeons, or pediatrician, it depends. In specific cases, but it's used nowadays.
I think one of the things that we have.
I think that Najia, she can tell us because since just some months ago they have started a very new lab on molecular biology.
Yeah,
which is
we just started. Yeah, we just started a work with with the Mount Sinai Hospital in New York with Isabel Germano, especially about biology, molecular, and glioma. And we started now, I think, 3 or 4 months. We did it routinely and in all the brain tumors. We need time to, of course, review all the cases and give, of course, the result of the study. But as Professor Khamnishi said, there are many immunohistochemically tests is already existing in many university department outside Rabat and Casablanca, now I think in Marrakesh and Fez and other countries, but not all the reactive is existing till now. But in our university, we have now all the reactive. We started this study. I hope that in a few months I will give you, of course, our results. Thank you.
Maybe we can have now Professor Bouyousef. He had some troubles with his connection, but he's here now, and he will talk of how his experience in the field of medulloblastoma, since he has dealt with it since many years. Professor Bouyousef, please.
Thank you very much. Sorry, my connection is very bad. Thank you for this very nice webinar and this discussion, very warm, about medulloblastoma and resection. I think that is not problem of a volume, the size of the tumor. There is not one medulloblastoma, it's many types, many subtypes of medulloblastomas. When we start our job 10 years ago to try to give a new algorithm for medulloblastoma, for high-grade medulloblastomas, at this time we do only ETV, CSF sample, and only biopsy by endoscopy. When the tumor is very high grade, we don't perform any surgery. Just the patient is treated by chemo and radiotherapy. And I have showed many times the results. In sometimes 2 months later, the tumor which occupied all the posterior fossa, 2 months later disappeared. This is why I tell that this is not problem of size, it's problem of behavior of the tumor itself. And the second comment is, I think that the management of the hydrocephalus, because the high grade of complication of VP shunt, we prefer first perform endoscopic third ventriculostomy before the operation, and in the same time we can, if the aqueduct is very large, we can go inside and perform a biopsy, and at this moment we can know what is exactly which kind of medulloblastoma we have. But we prefer endoscopic third ventriculostomy to VP shunt because the high level of complication, mechanical and aqueous. Thank you very much.
Good.
Thank you very much, Dr. Bouyousef, for your contribution. Yeah, I agree with you. If you have the possibility to do endoscopic third ventriculostomy, is the best option. But when the patient is referred for another center with a VP shunt, we doesn't touch, we doesn't took out this VP shunt. We just keep it going. About biopsy and only chemotherapy, we don't have this policy in practice today. We prefer to have a frozen analysis during open approach and try to do the maximum resection even in the high-grade medulloblastoma. I don't know if the colleagues have this approach, try to biopsy and do chemotherapy first and surgery afterwards. Usually we try open straight away and no biopsy. We do this possibility, third ventriculostomy and biopsy, when we have pineal tumors. On pineal tumors, yes, is our protocol too, but for posterior fossa tumors, no. Did you have this protocol too?
Yes, we have. In this protocol, we have 25% of medulloblastomas, which are not for surgery. 25%. One patient for is not for surgery, because these young people, the young child, are in very poor condition, and the surgery is the open surgery is not needed, because the chemo and radiotherapy give us very good results, and surtout even this kind of subtypes are spread with metastasis, supratentorial and spinal metastasis. I think that surgery, local surgery in posterior fossa, is very, very bad for this kind of people, of kinds.
Can I make a comment, please, about
Yes,
Yes, please.
You can.
As everybody knows in the audience, I have some discussion with my mentor, Professor Bouyoussef, about the extension of resection in medulloblastoma. And in the past, really, when we didn't know the 12 groups, and when we didn't know all these biologic things about medulloblastoma, I was totally against. But now when we are looking at the papers that are published concerning EOR and the subgroups, it appears that a near total versus a subtotal resection, there is no statistical difference, only for the group 4. This is an important thing to take in care. So as in the past was saying Professor Schultz, 90% of the tumor is maybe sufficient for these children. And I'm asking myself also about this dogma of 1.5. About the residue tumor, and maybe, I think maybe in the future we will have a very small subset, such as the sonic hedgehog gamma subgroups, that maybe can benefit from these biopsies, because we know that we have to look at the quality of life in these young babies. So I think that maybe, I say that with very cautions, but maybe this subset of patients will benefit from this policy of biopsy and adjuvant therapy. What do you think, Professor Boop?
Well, I think the concept of maximal safe resection is where we are. If you can't do it safely, then you shouldn't do it. I agree, we don't go into the brainstem, we leave tumor on the brainstem, we don't sacrifice cranial nerves or important vessels if tumor is stuck to it. But I think adjuvant therapy, like radiation and chemotherapy, do best cleaning up small amounts of residual tumor, but they don't do a good job of taking care of large lumps of tumor. So if we can get rid of the large lumps and just leave little bits of residual here or there, those children, I think, will do the best.
Thank you. May I ask another question to my friend Ailem and to the audience? You spoke about vinblastine as a first regimen in PLGG. And you have also put a wonderful sentence that among the prognosis factors, we have the environment. And I just want to say to you that, for example, in our pediatric neuro-oncology group, we would like to give vinblastine as the first line of chemotherapy, but we could do that because a lot of our patients are very far from the centers, and so they have to have weekly doses of vinblastine, and so that's why we prefer in these patients to use a shim with carboplatin. So of course, and this is also maybe will have an impact on our results, but we have to deal with the environment.
It is correct, but like, you know, when you look at all the studies that are being going, I think vincristine and vinblastine are like, you know, in terms of side effect and toxicity, about similar. The one good thing is you can administer them weekly. You don't have to administer them daily. The monotherapy that I was actually coding is from a hospital for sick children from the Toronto group that we also use. And I believe that Dr. Boop and his group is using like monotherapy for these low-grade gliomal tumors that are progressive or unresectable with progressive disease. Of course, when you're treating patients, you have to take into account the resources that you have. I totally agree with you. You look at the studies, I think the progression-free survival and effect and toxicity is most similar in most of those, like vinblastine and vincristine and first-line and second-line therapies.
Thank you. Professor Boop, any comment about the environment as a prognosis factor?
Well, just we use the combination of vincristine and carboplatinum or vinblastine carboplatinum as upfront treatment for low-grade gliomas. And then when those fail, that's when we use the targeted therapies nowadays. In our country, we have to use they have to fail standard therapy before they can go on to experimental therapy.
Thank you, Frédéric. So I
think
do
that
you want to?
I have a comment.
Lydia want to make a comment, Morad.
Yes. In our experience in Algeria, there is two parts in the treatment of the tumors of the childhood in the posterior fossa. We have problem with radiotherapy when the child is have 5-year-old or when the child is in the age not permit to have radiotherapy. The prognosis is not very good. We have a lot of problem with metastasis. We have in medulloblastoma. There is many problems. Better when the child have more than 5 years. We have the problem with the pediatric colleagues. They refuse the chemotherapy for other tumors, glioblastoma of the brainstem. There is problem with these patients. Treatment of this patient, chemotherapy is difficult to have chemotherapy. We have not molecular biology in our quotidian in our practice. It's only the molecular biology is only for the tumor, other tumor, the tumor of le sein, comme on appelle ça, souade de sein en anglais. Tumeur du sein.
Réponds.
Breast cancer.
Breast
cancer. Priority is the breast cancer. It's not the tumor of the tumor of brain. Not priority in biologic, in molecular biology. And we have a lot of program for the treatment of the tumor of the childhood. Medulloblastoma is not very great, very important surgery. We can have a good result after the resection, limit resection. But we have a surprise of metastatic location. Voilà, donc I think it's...
So thank you, Morad. Excuse me, thank you. But time has running, and I know that many of our colleagues, the Moroccan colleagues, have a webinar that has already begun, a very interesting webinar. And Professor Boop should leave us now, and he gave us a lot of time. So please, I want to thank all the participants who have attended this meeting. We have had many attendees from many continents, from all the continents, Latin America, North America, Asia, Africa, France, and of course, our colleagues from the Maghreb, which is the same, the country from Tunisia and Morocco and Algeria. And I want to thank, of course, all the speakers. You have given very, very interesting talks, amazing talks that have emphasized on the problems, not only on the technical aspects, but the reality of things in pediatric tumor brain. And I want also to thank Professor Boop to have been with us during this webinar. He's a mentor for a lot of us in the matter of pediatric neurosurgery. And thanks to him to accept in a very short time the invitation. Thank you also to my friend Morad Bouaziz from Annaba, who accept also to be with us with the Algerian Society for this webinar. And also thank you to Professor Bouyousef, Professor El-Khamlishi to attend to this webinar. And also I want to thank the coordinators of this webinar of the Algerian Society, Professor Houari, who is not with us today, but also, of course, Nabila Tirilt, who many of you knows, and she's doing also a great job in this field of, neurosurgery, women in neurosurgery, and she is au taquet, as we say in French, with these webinars. So thank you to all of you, and I hope we can see each other for another webinar of pediatric neurosurgery, maybe malformations. Thank you so much.
Thank you.
Thank you. Bye-bye.
Stay safe, everyone. Bye.
Congratulations.
Merci.
Excellent.
Super. Bye-bye. Thank you.
Bravo, Swat.
Bye, everybody.
Bye.
Ciao.